Well, good afternoon, everybody, and welcome to the Campaign for Better Care's Atlanta Roundtable on making care better and safer. I'm Christine Bechtel. I'm the Vice President of the National Partnership for Women and Families. We're a nonprofit consumer organization, and we lead the Campaign for Better Care along with a number of partners, including Community Catalyst, the National Health Law Program, and the Leadership Conference on Civil and Human Rights. And this is a campaign that is really about making the healthcare system work for patients. And we focus primarily on older patients who have multiple chronic conditions, who are complex and typically need a lot of health care, because our theory is that if you can make the healthcare system work for them, you can make it work for anybody. So the question is, why do we need safer care? Well, because each year more than 100,000 people die of medical errors, and nearly 2 million get infections from healthcare facilities that actually make them sicker. And that's true for all of us, but it's especially true for minorities. These are not just statistics for us. These are patients, their families, their friends, their healthcare professionals as well, who are all impacted by the stress and the strain of illness and injury that they didn't expect and they didn't intend. So we have a real problem on our hands, financially, but also in human terms. And this is the point that we are here to talk about today. Everybody in this room is interested in being part of the solution, and I think that is absolutely fabulous. We are so delighted that you're with us today. We have a great mix of consumer advocates and leaders from the Atlanta area, and healthcare providers, and federal and state and local federal or agency officials. And today, though, I think it's important to understand it's not about blaming or beating up on the healthcare system or our healthcare professionals. It's about creating change on a scale that we've never seen before. It's about leveraging what I think is the greatest untapped resource in healthcare to facilitate that change, and that is involving patients and families and their advocates in designing a better system that routinely delivers the right care to the right person at the right time every time. So, you all are here with us in the room today because you want to be part of this solution. And we've got an incredible lineup for you here, a mix of consumer advocates and healthcare providers on the panel, again, as well as in the room, who know from firsthand experience that we can create healthy hospitals. We know how to do it, and we know that it works. And in fact, in an article that was published in 2008 by the Institute for Healthcare Improvement, told us something important about hospitals who were successful at improving care. And what it said was this: in a growing number of instances where truly stunning levels of improvement have been achieved, leaders of these organizations often cite putting patients and families in a position of real power and influence, using their wisdom and experience to redesign and improve care systems as being the single most powerful transformational change in their history. So this is some incredible work. IHI, the folks who published this article, clearly they get it and have been preaching it for years. And I'm really proud to tell you that the leader of IHI in 2008, when that article was published, is in fact the same man who is now the administrator of the Medicare, Medicaid, and Children's Health Insurance programs at CMS, and that's Dr. Don Berwick. So we're delighted to have him here today. So it's no surprise that Dr. Berwick launched something called the Partnership for Patients. It is a signal of the federal commitment to reduce hospital-acquired infections by 40% over the next 3 years, and to reduce readmissions to the hospital by 20% in that same time frame. And importantly for our purposes today, the pledge that healthcare professionals signed to become part of the Partnership for Patients also signals their commitment to engage patients and families in their healthcare facilities in being part of the solution, in being part of quality improvement, in being part of redesigning the system of care to make it more patient-centered. So Dr. Berwick's leadership is exactly what we need at this time and in this initiative. If you haven't read his article on patient-centered care, Confessions of an Extremist, I highly recommend it. It shows you the depth of how patient-centered he is to his core, and we're honored to have him here today. So we are also honored to have a number of people with us. So first of all, Yolanda Chancellor, who is both a patient and has lots of experience as a caregiver, and she'll be sharing a personal story to get us oriented toward what we're all trying to achieve. We have Helen Butler, who is the Executive Director of the Georgia Coalition for the People's Agenda. We have Chai-Wan Kim, who is CEO and President of the Center for Pan-Asian Community Services. And we have Holly Lang, who is the Hospital Accountability Project Director for Georgia Watch. On the healthcare provider and provider-oriented team, we have Ted Johnson, who heads the Emory Center for Health and Aging at Emory University School of Medicine. And we have Adrian Mims, who's the Medical Director for Medicare Quality Improvement at the Georgia Medical Care Foundation. And then finally, we have Nancy Morrison, who is the Program Director for 60-plus older adult services at Piedmont Hospital. So we really want today to be about finding the concrete steps that we can take together in partnership to make our healthcare system better. So we have a real example and an opportunity here in Georgia to find ways to build those partnerships and deliver care that is really different in a meaningful way for patients and families, to redesign the system together. And our next speaker knows that field better than anyone. So please join me in welcoming Dr. Don Berwick.
Thank you, Christine, and thank you all for the chance to join you here this morning. I'm really delighted to be here. Let me express my personal thanks to Christine for her leadership. I have known her prior to her current role with the National Partnership when she was working with the eHealth Initiative and the QIO system with AQUA, the Association of QIOs, and she's been a leader of enormous value to our country and continues to be so. So thanks a lot, Christine. My job is probably best to get out of your way and so you can hear from real experts like Ms. Chancellor and the other members of the panel, but I thought I would give this conversation a little bit of context back to the scene that I'm in right now at CMS and Department of Health and Human Services and the administration overall, where we're headed. Christine mentioned the flagship effort right now, which is called the Partnership for Patients. That's something that Secretary of Health and Human Services, Kathleen Sebelius, launched with me and others in the administration a couple of months ago in order to improve care. The initiative is motivated by the facts that Christine mentioned to you. Too many Americans are being harmed by the care that is supposed to help them. The numbers are rather stunning. In a report that the Health and Human Services Inspector General did published last October, a study of 750 or so Medicare beneficiaries in hospitals asked the question, how many were significantly injured by their care? And the number they came up with was 13.5%. About 1 out of 7 people has a significant injury from the care that was supposed to help them. And about half of those, right off the bat, were judged to be preventable. That's tragic for the people who get injured. It also wastes a lot of money. Treating those injuries costs the Medicare system, in the estimation of that report, well over $4 billion a year in just wasted care. If we could avoid those injuries, the people would be better off, as would be the families, and it would cost less. Among chronically ill adults, if you go out and ask them how many of them can report a serious error in their care, repeated surveys of chronically ill people in our country show around 20 or 22% say that they can remember a serious error in their care in the prior 2 years. And then quite stunningly, just 2 months ago, in the journal Health Affairs, which is a major policy journal in healthcare, David Klassen, a former colleague of mine and a team, reported out using a very advanced method of looking for injuries to patients that when they looked in hospitals in our country, about 1 out of every 3 patients in the hospital had some form of injury from their care. These are rather stunning numbers, rates of harm. They sound surprising at first, but actually when you think about it and reflect on your own experience, you may not end up being so surprised. Let me ask you a question. How many people in this room know of a friend or a loved one, or maybe yourself, who has been injured by care? That is, there was a complication or an error, something went wrong that made you wonder, how could this happen? Just raise your hand. Well, I've done this in many rooms, and 90% of your hands are up. As stunning as these numbers are, 1 out of 3 patients being hurt in care, it's actually part of our familiar, almost daily experience. we're all in this together. The experience is quite common, and I think the Partnership for Patients can tap the energies that are latent in that shared experience. I'll bet a lot of you didn't know how many other people have been sharing that experience with you, and what Christine and leaders like you are contributing is a chance to get us together around a problem that we say, oh, it's a problem we all have. Now, this is not, and I really want you to understand this if you don't already, although you probably do, this is not a matter of calling into question the goodwill or the commitment or the motivation or the skill of the healthcare workforce. The doctors and nurses and pharmacists and managers, those who make up the people who give care, they want nothing more than they want patient safety. They don't want anyone to be harmed. The workforce isn't the problem. Every doctor, every nurse, every pharmacist, every steward of healthcare out there learns from day one that the first rule of healthcare is do no harm. First, do no harm. I was taught that on the first day I was in medical school. You're not there to hurt people, you're there to help them. And every day people come to work trying to prevent the harm. I was reflecting, flying down here this morning, about experiences in my own background as a caregiver. I practiced pediatrics for over 2 decades, and I remember in training a couple of very, very dramatic cases where I was directly involved. In one case, giving the wrong blood product, the wrong transfusion to a baby. The baby made it, but not because of that mistake. We had to shepherd that kid through a lot of trouble in order to get him back on the road. I felt terrible. I was in a system in which I blame myself. Now that I can reflect on it, I could recognize in all of the texture of the training system and the way the hospital set up and the way the blood bank worked, all of the what are called latent errors, the flaws in the system that set me up tired at 3 o'clock in the morning to have that kind of error. I still feel guilty about it, but I also know scientifically that we could have prevented it, and it can be prevented by redesign of systems to protect human beings from their own frailty, from the things that go wrong in our own daily lives. I have 4 children, and I mix up their names all the time. I hit the wrong button on the radio. I dropped my cup of coffee. I spilled one on me this morning. We're frail, and so safe healthcare has to be designed with respect to human frailty, and that's the secret behind safe care. Despite those efforts, therefore, millions of people get hurt every year in the healthcare system, and the good people, the doctors, the nurses, they get trapped in flawed systems. What we know is that burden is not inevitable. We know how to eliminate injuries of that type. The way to do that is to improve the systems of care that allow the doctors and the nurses and the pharmacists and the others to do what they really desperately want to do, which is to give care safely. Blame and accusation are not the answers. Teamwork, improvement, optimism, they are. We didn't make commercial air travel safer by yelling at pilots to please don't crash. That's not what happened. We engineered aircraft and safety systems and air traffic control to be safe, and we can do the same in healthcare. And we have examples where it's happening. There are hospitals all over this country, really all over the world, that have driven different kinds of injuries to patients close to zero, in some cases zero. Bloodstream infections from intravenous lines that I thought were inevitable when I was in training turned out to be eliminatable. We have hospitals that have gone 4 or 5 years without a single bloodstream infection from an central intravenous catheter. Pressure sores for patients who are in bed for a long time. My own father had a pressure sore in the last year of his life. They're almost eliminatable. Pneumonias that you get from respirator machines can be abolished. We have, again, hospitals that have gone years without a single pneumonia. We can do it nationally. The Centers for Disease Control reported a couple of months ago a 58% decline nationally in certain kind of infections, central venous line infection in intensive care unit. Why? We decided to tackle it. We got the science straight. We took the great places that had knocked the socks off that problem and then made that the standard all over the country through learning and sharing and collaborative work. We can do that for readmissions too. Another part of the patient safety initiative, the Partnership for Patients, is to reduce needless readmissions. About 1 out of 5 Medicare beneficiaries who goes home from the hospital is back in the hospital in 30 days, and most of those readmissions are completely unnecessary, and the patient doesn't want to be there, the family doesn't want them there, they want them home and healthy, and we know how to do that. There are demonstration projects all over the country that have done that. We know that what you're engaged in this work you're doing together here in this partnership, is essential to that. Every single time we find success, as Christine mentioned, we find patients and families and communities at the center of the action. They're not in combat with the healthcare workforce, but we're joining hands, and we're using all the resources that patients and families and the workforce can bring together to prevent these issues. Your voice is crucial. We find leadership from the professional community at the core of it, doctors, nurses, managers, leaders, executives, boards of trustees, and people like you out there in the community who say, no, this is not what we want. Care will be safe. Now, how can we help? What can we do? Let's get this done. It's a combination of a kind of acknowledgement, a demand, and then a reaching hand to help out. It can look easy. We know, for example, that checklists make care safer in the emergency room or in the intensive care unit or in the operating room. Why not just use a checklist? Well, why not just wash your hands? Well, if you go into a hospital and you watch the complexity of those systems, you realize how tough it is to the culture change, the technical change, the changes in flow that are needed. They're not simple. They take culture change and a lot of effort inside organizations. We need your voice to help get healthcare onto those trajectories. That's why the Partnership for Patients is reaching out so broadly. It is a partnership not just to people that give care, but all the stakeholders in healthcare, employers, insurers, patients' right groups, professional societies, associations, all coming together. Literally thousands of people. We have, I think, close to 2,000 partners now signed up, and we're headed for many, many more. The Partnership for Patients, as Christine said, is aiming to reduce hospital-acquired conditions. Those are things that go wrong that don't have to, like those pressure sores or medication mix-ups or post-operative infections or surgical complications. But to reduce all of those hospital-acquired conditions by 40% over the next 3 years, a very, very bold goal, and to reduce those unnecessary readmissions by 20%, an equally bold goal. If we do that, care gets better, costs fall, your loved ones live longer, families are more intact. Achieving these goals is going to require a lot of our country. We have to decide to do this, and thoughtfully, respectfully, we have to build in incentives like measurement and transparency and payment, to some extent regulation, but most of all, energy, building the sense that this is the healthcare system we want, need, and can have. And we need to learn together. It isn't easy, and so what's done in one place can be taught to another if we arrange an environment, which the partnership is doing, to help successful places teach those who want to be successful. And then we need to bring it to scale. I just don't think we need to have a situation in the country where you roll dice about safety depending on where you go. It's not okay for some hospitals to be very safe and others not. No, if we know one place knows how to do it, we all can. The Innovation Center, the Center for Medicare and Medicaid Innovation, which is part of the Affordable Care Act that was passed last year, has given us $1 billion of resources to devote to this patient partnership. And a lot of that will be used to reach out to professionals and institutions around the country to help them make safe care. There will, in addition, be a group of advanced participants. These are hospitals who aren't just going to stop with hospital-acquired conditions, but are going to go for everything. They're going to try to get to zero for all kinds of complications. And they may be fewer among us, but they'll be the vanguard, the teachers for everybody about how to get there. The question to keep in mind, you, as you do your remarkably important work, and that we're trying to keep in mind with a partnership is that it's a simple question. If there, why not everywhere? If Seton Hospital in Austin, Texas can go 10,000 deliveries with only, I think, 2 birth injuries, why can't everyone do that? If Ascension Health can reduce pressure ulcers by 95% in every one of its hospitals, why can't everybody do that? If I was at Nationwide Children's Hospital in Columbus, Ohio last month, they've reduced surgical complications in kids by 60%. If they can do it, then why can't we bring it to full scale? Why can't excellence be the norm? That's the challenge. I'd love Georgia to prove that, bring it to full scale right here. We're in this together. This isn't about blaming or finger pointing or beating up on each other. It's about getting everyone together, boards, clinical leaders, executive, hospital systems, and you, consumers, employers, providers, those who are really in the trenches, both getting and giving care. The partnership has gotten a great start. It's an important alternative in the policy scene right now. If we don't improve care and use that as a tool to make care sustainable, better for everyone, higher value and lower cost, which this can do, then we're headed down a different road in this country in order to get healthcare contained, and that's to cut costs. And I don't think that's a good idea. I think we can improve our way to sustainability. And so the Partners for Patients and your work on patient safety and readmissions is directly connected to a healthcare system that's sustainable. We know how to do it. We know how to improve. We know how to do that all over the country. Now bringing that to full scale is a thrilling and plausible agenda, and with your help, I know we can get there. In CMS, we're calling the overall goal the 3-part aim: better care, better health, and lower cost through improving care. And that's the answer. better care, better health, and lower costs through improving care. As you listen to the stories of my co-panelists, listen for those messages, how to make care better and more sustainable at the same time. Thank you for your efforts. Thanks for your leadership, Christine. I look forward to hearing the panel.
Thank you so much, Dr. Berwick. I'm just so excited about this ambitious goal that CMS has set with Dr. Berwick's leadership, and I absolutely know to my core that it can't be done without consumers and advocates and patients and families at those tables. So with that in mind, we've asked our panel today to give some brief remarks, a couple of minutes each, to talk about their experiences, the work that they're doing, the great work they're doing locally, and the leadership that they're demonstrating as a way to kind of spur our thinking about what we all can do to engage each other, consumer and healthcare provider, to join hands, as Dr. Berwick said. On your table and in your packets, there's a copy of a document that we'd love for you to keep in mind as you listen to the panelists. And this is sort of a menu, a list of the kinds of things that hospitals could do to put patients and families at the center of their redesign efforts, and that patients and families can really be part of that re-engineering that Dr. Berwick talked about. So keep that in mind, and what we'll do is we'll have our panelists give some brief remarks, and then we will talk as a discussion and have a roundtable about what we can do next. And of course, we'll answer your questions. I know we have Dr. Berwick. We'll lose Dr. Berwick, unfortunately, at about 1:30 because he's obviously busy and important. But nonetheless, we will use his time wisely, and we can continue our discussion until about 2 o'clock. So with that, let me ask Yolanda to kick us off.
Okay, greetings everyone. I'm really happy to be here, and thanks to Helen Butler. She has allowed me to chair the health committee with the Coalition of People's Agenda, and with Dr. Joseph Laurie. And I am really moved listening to you because there is such a need, for excellence and integrity and respect for patients who cannot care for themselves, who cannot speak for themselves because of the conditions that they're in. And the two people that I could go talk about, a lot of people in my personal journey, but my grandmother was misdiagnosed for diabetes. She was given, you all can read the bio that they put together for me because it's so lengthy. But some of the things that my grandmother experienced, she was over anesthetized. She was, her kidneys failed because of the diabetes, because they did not, because they didn't diagnose her at a proper time. And it's because of my mother, who's here with me. She's a retired registered nurse. She's done obstetrics, psychiatric nursing. She's done substance abuse nursing, obstetrics, just a lot of things. I grew up in hospitals. And as my mom mentions to me, there was no staph infections when she was in nursing. So as he said, it's so simple. Wash your hands. Make sure the visitors that come in wash their hands. And I just wanted to also say that the love of my life, if you ever have someone in your life that is just makes your life is more positive than negative, you're blessed. So and that's what I had in him, and I miss him truly, because the guys that I meet now, they don't stand up at all. So I said, if I never love again, I never sought out to say that. You hear that adage, if I never love again, at least I loved. That's how I feel right now. But he was hospitalized he took himself to the hospital. Him and a friend. He called me and said he was having chest pains. He went to the hospital. They admitted him. They said he had to have bypass surgery. And to make a long story short, that turned out to they needed to do triple bypass surgery. They moved him to 3 hospitals in the process. And when he went into surgery, I talked to him the night before. He was fine. He was livid. He was laughing. He was joking, as he usually does. We prayed, and that was it. After his surgery, he had a seizure. He was acquired staph infection in the hospital. They were actually never able to get rid of it. And he ultimately succumbed over a period of them trying to antibiotics and different things that they were doing to him. And the most profound thing that occurred was that he was one day he was dehydrated and he yawned. And when he yawned, I could see where the nebulizer, because he was asthmatic, that they'd given him, his crust had formed on his tongue from just no moisture, no hydration. He maybe cried like I am now because he couldn't speak, he couldn't move, he was immobile. And his eyes had sealed, and none of the nurses recognized that his eyes had sealed. And I went to dialysis with him, and I got some compresses to put on his eyes. I asked them, I said, can't you all see that his eyes are crusted, he can't open his eyes? And a lady said, he hasn't opened his eyes since he's been in here today. And I said, well, I guess not. I mean, they're sealed. So I got warm compresses. I had to ask for warm compresses. They gave me gauze. I mean, you know, you're gonna put gauze, what is that gonna do? That's gonna hurt more. But I digress. I wanna move on to, but he's gone, and it's because of inadequate health care. And I had my best friend, my high school friend, just lost her brother. He was also in and out of the hospital. They misdiagnosed him, but he had cancer. So by the time his doctor recognized and did a CAT scan and identified the cancer, it was too late. So he passed away this year. And I have also just several of my family members. I've just bought obituaries. My grandmother, my uncle in Las Vegas, MRSA. My grandmother, someone had just diagnosed she was going to have a stroke. My cousin had an aneurysm. She also passed away, MRSA in Chicago. My cousin in Iowa had lupus, MRSA, and of course the love of my life. And this is my friend Cynthia, who just couldn't afford a CPAP machine. So she died in her sleep. So I just feel, in wrapping up, that they should rate hospitals and doctors like they do restaurants. Put a sticker outside the door. Let me know how responsible they are. Let me know how clean they are. Let me know the statistics and the quality of their care that they provided based on the number of patients that they've had. And I thank you very much for listening.
Thank you so much for taking the time to be with us today and to share your really heart-wrenching story. But you already heard Yolanda's got a lot of ideas, right? Put her at the table. Let's get those in play. So, Ms. Helen Butler.
Well, good afternoon, everyone. I'm Helen Butler with the Coalition for the People's Agenda. Of course, we are an advocacy group made up of representatives from the civil rights, human rights, environmentalists, peace, justice, young people, women, legislators. We all come together to work toward a common good, as Dr. Lowry says, working for the common good of a better quality life for all Georgians and people in the southeastern area. What we do, of course, we work a lot on, we go across the state of Georgia and we hear stories like Yolanda's, many other people, and we've all experienced it. Communities of colors are impacted with disparities in healthcare. So that is a great concern to us. So we advocate primarily from a policy standpoint. We want to know what can we do to change those policies to help make the delivery systems much better, working with our legislators, but also working with our communities to educate them as well as knowing what their rights are, knowing what they can do to help make the care for their loved ones better. I've been impacted. I had a young niece that died at 11 from cancer, and other chronic illnesses in my family as well as my friends and family too. But what can we do to advocate not only for access to quality health care, but once you get that access, what kind of care do we receive? Is it really helping and beneficial to us to make sure that we improve? And once we've received quality care, what can we do as a community to ensure that we remain healthy? Whether we look at some of the environmental things that might be impacting us from a policy standpoint, what are those things that are creating asthma? What if those things that are creating cancers down in Berwick County with the nuclear power facilities? What are some of those kinds of things that we can look at as communities that will help improve the quality of care that our people are exposed to, and that they maintain a quality of life that would be good for everyone? So that's what the People's Agenda is all about. We're about making sure that we can help assist the people that come to us with issues like Yolanda's, that I can't find the right resources. How do we get that resource to them? How do we educate them in terms of where the resources are that provide the quality care? How do we educate them on what they need to know in order to know whether they're receiving quality care, and how can they themselves help with the quality of care? So that's what we're all about with the People's Agenda.
Thank you so much, Helen. And I think what Helen's story also says to me is the fact that when you bring patients and families to the table in efforts to change, you also have to think about bringing patients and families from a wide variety of communities, whether they be communities of color or communities of geography. They have different needs, they have different approaches, and different things will work, but we can all be part of creating an adaptable and a flexible system. So thank you. So next we have Ms. Chai-Wan Kim.
My name is Chai-Wan Kim. I work for Center for Pan-Asian Community Services. CPACS is the first and largest and longest standing Asian American social service and health service agent in South, focused on immigrant and refugees. Georgia is the second fastest Asian American population growing state, and CPACS has 10 different programs, and we serve 18 clients per month. CPACS assists immigrants and refugees to integrate to mainstream system. Medicare, Medicaid, and its support system helps patients to hospital and dismiss and transition service. But we immigrant refugee with a limited English population patients have a language and cultural barriers when we face the hospitalization. CPACS educate patients and families, help them with the language and cultural competence, but it takes more energy and resource and time. So all healthcare provider, when you encounter with the limited English, will you please be patient, and when they ask questions and over, because I've been patient with you all with a southern accent. One story that I have, Mr. Kwan, he is 70 years old, very successful businessman, have a 5 BP gas station. He is early bird, but his wife and him use a separate room. So one day, his wife wake up. His husband didn't wake up by 6:30 and 7. So she went his room, and he was just half closed eyes and waving to his wife. So Sunja thought he wanna sleep more. So she walked out. But by 10 o'clock, he didn't wake up. So she went back, and he was comatose. So she called 911 and went to the local hospital, and he had a stroke. But it hit his speech center, so he can hear, but he can talk, and he cannot talk, but have a hard time to swallowing. So that when the crisis over, the doctor moved him to the floor. So Sunja called us and asked us what his condition, and the doctor ordered him to go to the nursing home, and then he will get the feeding tube. So next 2 days they were looking for a nursing home and find the home, And then third day, he called me, Sunja called us that he's back to hospital. And so what happened? He said the nurse at the nursing home put the feeding tube in lung, not to the stomach. So he's been in hospital for 3 days and then passed away. So I've been thinking all the time, even on the way to here, I discussed with Marianne that how could we save this patient? Who is wrong? And what is a better care for this Mr. Kwon and Sunja? And this is all our problem, I guess, to solve together. Thank you.
Thank you, Ms. Kim. It's compelling. So we also want to hear from Ms. Holly Lang with Georgia Watch.
Hey everyone, and thanks for having us. My name is Holly Lang and I work for Georgia Watch. It's a nonprofit consumer advocacy organization headquartered here in Atlanta. And there I run our Hospital Accountability Project, which examines the policy and practices of hospitals in our state, particularly as they relate to vulnerable populations, your uninsured, underinsured, low income, as well as those with chronic conditions, those who have limited English proficiency, and generally minorities, as they are adversely affected more than most populations. Hospital safety has long been a priority advocacy at Georgia Watch, simply because we see the impact on patients daily. We are a consumer group that interacts with consumers, so we get calls, we talk to folks, we are out in communities often, and it's overwhelming the issues that people face and feel that they have no recourse for. Not only that, any adverse effect, regardless, can have a detrimental effect on a patient's physical and fiscal health. Dr. Berwick mentioned earlier the cost to Medicare in 2009, approximately $4.4 million in inpatient care due to adverse effects. It's a lot of money. Those with staph infections generally incur a bill that is about 3 times the average cost of an average patient's bill. As everyone's mentioned already, I don't think anyone's here wanting to point fingers at just the providers or, just this nurse or whatnot. This is a problem that we all need to face together, and we are here doing that. And we're excited at the opportunity to be a part of it. We take very seriously our role as a voice for the Georgia consumer, and we're excited and happy at the momentum behind this and just privileged beyond belief to be a part of what Dr. Berwick and the others at CMS has started and what we can build here in Georgia together in a very positive partnership of consumers, of providers, of folks who work in this every day. And even if your job doesn't land you directly in a hospital room, you can be part of the solution. So again, we're just really excited to be here, and I hope that everyone takes something from this in a way that we can all work together. Us as a consumer representative, these guys, providers, all of you. So thank you.
So now we're going to ask 3 local healthcare providers or provider-oriented organizations to share their perspectives with us, and we're going to start with Ted Johnson.
Thanks so much. I'm a geriatrician, and with the aging of America, geriatricians have an important role to play in terms of educating other providers as well as caring for the elderly. Unfortunately, geriatrics is the second least popular medical specialty. So at the time when we need to prepare for the aging and graying of America, it's a very unpopular specialty choice. It is more popular than geriatric psychiatry, though, which is also a highly relevant specialty for what's going on in Georgia. Georgia is one of the youngest states by percentage of population, with 9% of the state residents being over the age of 65. By the time 2030 comes along, that percentage will be at 20%. So we are aging rapidly, and the alternative is the aging is better than the alternative, which is dying. At the Center for Health and Aging, our mission is to enable older adults to age successfully within their homes and within their communities. This is something that's been talked a lot about nationally. Roseanne Leipzig at Mount Sinai published an editorial in the New York Times right about this time when the new house officers were coming into training in the hospital, and the title of the editorial was "Don't Kill Granny." I would argue a slightly different point than Dr. Berwick's earlier by saying that there are special areas of training and special areas of knowledge that are necessary in order to deal with an older and frail population. Nathan Flacker, who's over there in the corner, directs outpatient clinic where the average age of our patients is 87 years old. I would challenge you that that's a different population than a population of individuals who are in their 50s and 60s. It's a very different type of care, and it's very goal-oriented and focused, and it encompasses what goes on with the family as well. My father-in-law had the experience of becoming a Medicare beneficiary while in the hospital. He had his 65th birthday midway through a hospitalization, so that was an interesting and rather unique experience. One time, subsequent to that hospitalization, he was in an intensive care unit, and I took some time off work to be there for him as an advocate. I was waiting for the medical team to come around, and then when they did come around, they stood outside the door, they pulled the door shut, and then they talked for about 3 minutes, and then they left. And then when I opened the door, they were all gone. So that's not what we mean by patient-centered care. Jason Stein, who's back there in the other corner, has been implementing with Emory University Hospital what are called speed rounds. They're basically rounds that take place between 10 and 11 o'clock. They're 5 minutes per patient, so there's not a lot of time. But if you're a family member, you know when they're there. You know when they're coming by. The nurses are there, the families are there, the patients are there, and everybody on the team has an assignment as to what they're supposed to do in that targeted rounds. And if there's a question, people come back. Part of the mystery in communicating with health providers is where are they? And that's one of the things that this solves. There was an opportunity to redesign one of the hospital floors, and I got to sit in on some of that discussion. It became very clear that the nurses were arguing with the doctors, who were arguing with the clerks, who were arguing with the supply people as to what space was theirs. And at one point, somebody put up their hand and said, "Where's the patient's space?" And it was clear that that wasn't the initial consideration. At the two neurosciences ICU over at Emory University Hospital, they had a chance to fix that from the ground up. And basically what they did is they incorporated patient and family space that's adjacent but not in the middle of where the patient is staying. An opportunity for patients and families to be together and to have the staff and the nurses and all those folks involved in what's going on. I would also say that some of the problems that we're facing have a complexity, and that might be no mystery to you. If falls are a never event, do we respond to accidental falls in the hospital by restricting patients to bed? If you look at a lot of our programs, that's what's happening. If you look at trusted voices, if you look at restraints, if you look at bed rails, if you look at what we're doing, we're putting the patients back in bed. That's not what's good for them in the long run. There is that certain element of risk that you are going to take when you're mobilizing a patient as you need to while they're in the hospital. That's challenging. We've talked a lot about MRSA. MRSA has a very different approach if you're talking about an acute care hospital versus what you might be talking about in a long-term care setting, where we had to implement a policy that demanded that we separate MRSA positive from MRSA negative nursing home residents, and we were splitting up people who had been together for 2.5 years, who were their own family. So we do have to think about this. There's no question that we need to be more courteous. We need to be more concerned. We need to be knocking on doors when we're going into a patient's room, because it is their room. And we need to be demonstrating our concern for them by visibly washing our hands. There's lots that we can do in partnership, and one of the things that's been exciting about the Center for Health and Aging is how many times we're working with social workers and with nurses and with public health professionals, with consumer groups, with area agencies on aging and the like, and even other healthcare organizations that aren't our own. Thank you.
Thank you, Ted. Adrian?
Thank you very much. Good afternoon. For 40 years, Alliant GMCF has been working across the state of Georgia, providing quality improvement and peer review for Medicare beneficiaries. We stand ready to convene all of the stakeholders, many of you in this room, from hospitals to nursing homes to federally qualified health centers, the internists, the pediatricians, the family physicians, as we have been doing so for several years. And most recently, we've been working on a project trying to empower patients with diabetes. Well, why diabetes? Well, we know that Georgia and Atlanta is the belt buckle of diabetes. But we worked across the state training over 5,000 patients with diabetes. About 2,000 of those had Medicare. And what we did was empower them to understand their disease process, to raise their self-efficacy, to be part of that collaborative healthcare team. They came back and told us that no one had ever told me this before. And as we do this, empowering them, they are now ready to be part of that discussion so that they can turn that discussion and make it patient-centered. We have also been working and learning collaboratives, and as we go forward over the next several years, that's going to be a major way to get groups of people together. Across the state, we have convened over 15 of these community healthcare connections where we bring hospitals and nursing homes, home health agencies, pharmacy benefit providers, and clinicians to talk about key areas around patient safety. Whether it's reducing pressure ulcers and restraints in nursing home, whether it's reducing hospital-acquired conditions, whether it is improving medication reconciliation, we have seen that that collaboration of having everyone in the discussion at the same time makes a difference. But we hear that we have not had patients in the room. We take that as an honest criticism that we will change moving forward. As we have heard today, that is a voice that needs to be there and will help guide us going forward. So we are very excited about that. We have had some great successes. One of our collaborations in Macon has allowed a nursing home to change their culture and have the patient be the center of their care. And they've been able to empower the direct care providers such that rather than from taking care of a different patient every day, taking care of that same patient every day allows them to bond to that patient and notice when Mrs. Jones is getting sick and begin to take care of her so that she doesn't have to be rehospitalized. So we see going forward an opportunity to work with all of you in the room, have us all have discussions together around key conditions going forward. So thank you for coming, and we're glad to be part of the discussion.
Thank you, Adrian, and thank you very much for your commitment. Nancy.
Hi, good afternoon. I'm sort of wearing two hats, I feel, as I'm sitting up here because I have a husband who is now Medicare age. I don't know how that happened. And I am a baby boomer myself, so I take all of this very, very personally. And I think you cannot be in the healthcare arena today and not view it from both being a patient as well as being a provider. So that's sort of an interesting approach, I believe. You've heard about a lot of great initiatives that are taking place here in Georgia. I think one of the greatest things we see as I look out over this room, our partners are sitting here. We already work well together. Dr. Johnson mentioned the fact that hospitals are partnering. We can no longer view ourselves as competitors. We've got to support each other, and that is happening, and that is really a great thing for patients. And the other thing I hear a lot about is almost everything we do and every approach we take, the patient input is woven into that. We're looking at how can we restructure discharge in the hospital so it is safer. And the common thread is informing the family and the patient and making sure the patient is informed, but also more than that, making sure the patient gives input. What are the patient's goals for that discharge and when they go home? One of the things that Piedmont Hospital was very fortunate to be able to do was to receive a federal grant to do a 2-year initiative with care transitions. And we focused it on those work processes, communication flow, safe discharge issues with a partner home health agency, Visiting Nurse Hospice Atlanta. There were a lot of assumptions we both had about what happens to our patients when they leave and they're referred for home health. Some of those things, when we started our weekly meetings with our home health partners and looking at those patients that did come back and were readmitted within that magic 30 days, that we were finding there were things that we didn't do on our end, that they didn't do on their end, and also the patient didn't do on their end. So boy, is this ever a team approach. So we needed to look at, okay, what do we need to fix in our system? And we had to put all of our defenses outside the door and just sit down at the table and say, okay, we're all in this together. We have shared responsibility and accountability. and the sharing extends to our patients and their families. So what are we going to do about this? Well, one of the things that we did as part of that grant phase was we developed some very customer-friendly, consumer-friendly materials. And this was a joint effort of not just, we did surveys with patients, what works about this, what doesn't, but it was a community project. And so one of the things just to highlight, there's material back here about our Care Transitions Work Group. It is an organization of 40-plus hospitals, healthcare providers, area agency on aging, aging network service providers. We come together on a monthly basis to look at what we're all doing to make sure we help reduce readmissions, and we're sharing. I know Dr. Johnson's team with his Emory health coaches is coming to educate us this month about what they're doing, and we're all going to share from each other. So it is all about accountability and sharing. Thank you.
So I think we've heard some really important themes up here, and I want to get the discussion started. So I want to ask you to formulate your questions, and if you've got questions or comments, raise your hand. We will have 2 roving microphones, and I see we have actually a bunch already. So let me start over here. Yes, sir.
Hi, I'm Dr. Harris with the Essential Medical Clinic, and I'm Director of Community Health and Preventive Medicine. I was interested in knowing more about the grand rounds and having patients as part of the protocol in the grand rounds, because a lot of times when I was in medical school, we would have just the doctors and interns, residents, and the attending surgeon to walk with us, but then we never talk to the patient other than, just very basic questions. So I think that might be a good idea. The other and final would be looking at healthcare advocates, recruiting people within inside the community that our target population is in, because they know the culture, the people there. If you're in a Hispanic community, in an African American community, or Appalachian community, they know exactly what that culture specificity is, and they need to be able to look at the chronicity and the severity of the diseases or the different issues that they're having that we may not know outside of that community. Thank you.
Those are great ideas, and it's going to sound like we paid you to start there, because that's exactly what we're looking for. And I would say in your packets, again, you have actually a document that talks about things exactly like that: involvement in grand rounds, involvement in doing change of shift at the bedside, some other specific strategies. Our next question. Yes, ma'am.
Hi, my name is Joanne Yoon. I manage the Child Health Policy Agenda at Voices for Georgia's Children. First of all, thank you for all of the panelists and your insightful comments. I had a question for Dr. Berwick specifically about some of the initiatives that are grant funded through the Affordable Care Act, specifically electronic medical records or that kind of technology aspect, and also funding for patient-centered medical homes. I wanted to know how that ties in with the Campaign for Better Care, and also if there is any expectation of promising practices that emerge from either of those 2 initiatives to be implemented at a larger national policy level.
Well, thanks, Ms. Yoon. I'll be quick, but there's a lot to say. And the Affordable Care Act and the environment we're in now is full of opportunities for projects, demonstrations, and support. Electronic health records you mentioned, that's crucial. The kind of a lot of the mistakes in care we've heard about would have been mitigated or the odds reduced if information had been able to transfer around much faster than it can now, if the patient had access to their own medical record, if there was checkups so that the medical record would look for incompatibilities of medicines, for example. So there's a lot of that. As you know, now due to the prior legislation in the stimulus package, the ARA legislation, now hospitals and doctors all over the country can get support for modernizing their health records. You as consumers can be great advocates for that. We have to attend to issues of privacy, but it's really important to our futures that you be advocates for getting modernization. More and more physicians using electronic records, which is a hard transition for them, and more hospitals doing that would really, really help. The Affordable Care Act has in it mechanisms to help communities with community care transitions, such as you heard several of the speakers speak about. Nancy Morrison laid out how important that is as a as a support. Indeed, in the Partnership for Patients that we launched, remember I said there was $1 billion of support going in that. Half of that, $500 million is of support for community care transitions from a particular part of the law. And maybe most important, we now have a new innovation center. There's the Center for Medicare and Medicaid Innovation that's been funded to support innovations and then spread innovations all over the country. And in the authorization of that innovation center, very specifically, it has to do with finding improvements that improve care and reduce costs without harming patients, and then giving the Secretary of Health and Human Services the opportunity to translate those into broad-scale spread right away. The biggest effort so far that's come out of that center and brand new is the Partnership for Patients, which is aiming to change care all over the country. So I think you're going to see a lot of such supports emerge as a result of the policy environment we're in now.
So let's take a question from this half of the room.
Thank you for coming. I'm Clint Kalen. I'm with Health Students Taking Action Together, and I know we have quite a few incentives for being able to address patient-centered care and systems-based safety on the hospital and level, and it seems like that might be a little too late. And so I was wondering if the panel had ideas for integrating that sort of training into early didactic medical education, and because that seems like the best way to address a medical culture shift that we're going to need to make this successful.
Yes, Ted.
First of all, thank you for all the great work that HealthStat does, a courageous group of students starting from the bottom up and really trying to reform a lot of things, including safety net hospital access and the like. I'll point over to Manuel Esquilson, who's sitting on that side of the room over there. And one of the things that he's working at is a very practical matter, and that's how to teach medical students and interns how to do a better dictation summary. Dictation summaries are the dog of duties for medical personnel, and basically they go drop on down to the lowest person on the totem pole that has a code. And that's not how we need to enhance and enable our healthcare transitions. We need specific instructions. We need tools for how to do that. We need to look at the quality. We need to look at the discharge summary not as only a billing instrument, but also to figure out what is it that the long-term care medical director at the skilled nursing facility need when that patient leaves from the hospital, and not just what were the diagnoses and how long was the stay, but a real accurate list of the medications as well as the contact numbers for whom to get in touch with. A lot of times that weekend call coverage over at the nursing home is sitting there going, this wound is looking a little pink and the nurse is telling me it's splitting up. Well, somebody wants to know that right away, and we've got to be able to go back to that discharge summary and figure out exactly how to do that. That's one specific example.
Thank you. Other questions?
I'm Kim Traxinger. I'm a fourth-year medical student at Emory, and I feel like a lot of this has been to address lack of communication in the hospital between physicians or nurses and patients. But a lot of the times when I've seen the ball dropped with patients, either my own patients or patients in my family, it's been outpatient. One specialist not talking to another specialist, not talking to the primary care doctor, getting referred to another physician who then looks at the patient like they're crazy and why are you here? And so I wonder if anyone had any response to how to address the outpatient problem with lack of communication, a lot of times lack of ability to see your own health records and bring your health records to your appointments, but just any sort of addressing the solutions to that problem.
Adrienne?
Yes, that's a very important discussion, because what we find is that even though patients are now being cared by physicians who are on electronic health records, they're not speaking to one another. And so within Georgia, we've been funded to start the Health Information Exchange, and Dennis White, our CEO from Alliant GMCF, chairs that board. And what we expect that will be is a electronic vehicle that the specialist can actually send that information back to the primary care physician electronically rather than relying on the patient to carry it, and that they can actually communicate to one another, even if they're not on the same insurance plan or they're not using the same health program. But what we're trying to do now, short of having that health exchange, is being able to bring that issue up to clinicians and making patients aware. Now, the example that Nancy mentioned, that they have a document at Piedmont Hospital. We've also promoted a personal health record that the patient can be empowered to know what their medical conditions are, know what the appointments that they have, and their medications, and to carry that with them from one vehicle to another. We hope that in the future that will be electronic, and that will occur. But for now, we're trying to empower the patients to take charge of their health.
And I'll add one thing to that, which is, as you think about, particularly in the outpatient setting, but also in the inpatient setting as well, one thing that is critically important as sort of an overarching strategy is getting patients, families, and caregivers in the room to give you feedback about your care, because if they're the same as the people that we've talked to nationally across the country, thousands of them, they will tell you, my number one, number two problems are communication and coordination. All I want you to do is talk to my other doctors. How hard can that be? When you set up the systems to get the feedback in the first place, that's really the core of what we're talking about today, are setting up, whether it's inpatient or outpatient, systems and processes so that healthcare professionals can receive input from patients, and so that input has an impact, and that can be part of being what the solution is in changing our systems of care.
We have great examples of that
Yeah.
to spread. Cincinnati Children's Hospital a few years ago tried to redesign its cystic fibrosis care, which really raises a lot of the issues Kim was talking about inpatient, outpatient coordination. They had families and children with CF on the design team. They actually didn't just act as the patients receiving care. They designed the care with the hospital. Here at the Medical College of Georgia here in Augusta has done some similar kinds of exploration, so it's really possible.
Really possible. Yes, ma'am, right here.
Well, I've had the privilege of working with Nancy Morris in Piedmont and Emory and visiting nurse. So my question for you, Dr. Berwick, is when we find things from these grants that are working, like care coordination, how will that be funded through Medicare?
Well, first of all, you can help a lot just with spreading the knowledge. I'll answer your question about Medicare, but what you're setting up here, which we used to say when I was at IHI, all teach, all learn. You know, what's discovered in one place can be used other places, even if nothing else changes, if people just know about it. And this commitment to spreading good news and moving it around is really important. The quality improvement organizations can be great assets at that. The Partnership for Patients has all sorts of regional collaboratives planned and already beginning to take shape where we can spread the news. And I think there'd be a lot of uptake with that. Also in the law, in the new law, as I said, when innovations come along that are certified as improving care and reducing cost, a very important area of improvement, the Secretary for Health and Human Services has the authority now to translate those right into regulation, right into payment policies without going back to to Congress for doing that. So I think we're starting to get the idea as a country. If we know what the best is, why don't we do it? That's not just a government thing, though. A really, really important thing is we're all in this together, the public and private sector. So it's not just Medicare policy, as relevant as that is. You have the private sector ready, willing, and I hope able to do that kind of spread. It's partly the way we think. It's if someone can do it somewhere, why don't we all do it? That's the relentless theme that I think it's time to pick up and embrace.
We have a question over here.
Thank you for being here. I'm Monica Beshara. I'm a nurse practitioner and I make house calls. My question is for Dr. Berwick. Since home care is becoming a bigger market for providing physician-oriented care, do you have a forecast for better funding for such programs from Medicare so that we can better keep our patients in the home, aging in place where they're safe, happy, and healthy?
I couldn't endorse that more. People don't want to be in the hospital if they can be home. And we have a healthcare system that's got to really orient itself toward that idea of being where you want to be so you can heal in the best possible supportive climate. It's not just Medicare, it's Medicaid as well. And you're seeing in the shift of policy over time, rebalancing from thinking about institution-based care to home-based care, moving people from hospital to home, better care transitions, more support for home and community-based services. It's not easy because we have to really resort the competence of the workforce and the investments we're making about where we offer support and payment. But I think that process is underway now and will continue to be. Home health care is a very difficult area, extremely important. There are some problems with fraud and abuse in those areas, and we're very, very serious. And we all need to be about making sure that people are properly respect their stewardship of public and private funds. But I think that's just a part of the story. The greater story is how can we build a fantastic home health care sector in this country so that people finally can be where they really want to be, which is at home.
Yeah, I was going to say that in healthcare reform, when we're talking about the medical home, there's not much home in the medical home. It's really a different meaning of the word home. And I think that when you look at some health system issues globally, the Department of Veterans Affairs, where the payment incentives are totally different than they are in the public and private sector, you end up with a very different model where those initiatives where people remain at their home, it ends up happening in a very different way, in a much larger way. It looks like one of the home-based primary care programs that was very successful in the VA is going to be rolled out as an Independence at Home program with the opportunity for trying that outside of the VA system. So that's one thing. I know that when we're looking at domiciliary care, when we're looking at assisted living facilities, we can often do those visits in a way that's economically feasible to do and see folks in their home, as it were, in a fashion that is about equal to us seeing them in the outpatient center. We've been moving towards that over at Wesley Woods.
Did I see earlier that Miss Yolanda's mother maybe has a question? We would love to hear from you.
My name is Mamie Chancellor. Oh, wow, okay. My name is Mamie Chancellor, and I am really very worried and concerned about MRSA, the infections, and the cleanliness. And I feel that hospital to bed, to the food, to the bathroom, and all those things, that the patient is sort of left out. I wonder how many times the hands are washed before they eat, or how many times they get that AM care or that night care. Because I really wouldn't want to wake up in the mornings, I don't know where I put my hands, and have to have my breakfast served, and I didn't get a chance to wash my hands. Some of us might not be able to say that, talk. And the cleanliness, it's almost like the gloves and the hand washing is to protect the caregiver or the doctor or the nurse. But then here is the patient. And it really concerns me. And I tell you, I'm scared because I'm getting there. So I hope that will be addressed and observed, because everybody don't know how to wash hands. So thank you.
Thank you. And you're not even close, Mrs. Chancellor. Nice try. So I'm going to take a moment and take a liberty and ask our consumer advocates a question. So as we talk today about really bringing forward these ideas, like Mrs. Chancellor just said, hey, how about, hand sanitizer for the patients? As we think about how we get patients in the room, how we get consumers or their advocates or representatives to the first question, how do we do that? Who are they? How can we get patients and families in the room? And what do they need from us in order to be there?
Just to start, I think the gentleman over there had a great idea at the very onset of the Q&A, which is to recognize the communities that your hospital serves or that you as a provider serve, and to engage either the representatives of those communities or, when possible, especially if you have patients or their family who are particularly articulate and really understand what's going on in the care and in models or developing models for future care. We talk a lot about language and proficiency and whatnot. Cultural competency is something to definitely not overlook. And that's where your Hispanic communities, your groups like CPACs and whatnot can really be a benefit to each hospital and understanding what cultural barriers may exist with care and ways to overcome them. We're a big fan of having as much consumer involvement with hospitals and providers as possible. And I think that increasingly so, others are seeing it that way, and we're really excited about some of the partnerships that are being forged and through some of the Affordable Care Act provisions that are bringing together the community, public health, and facilities and other conversations. And I think this is one that should be incorporated into those greater dialogues.
I also think that we have to all do an outreach with the communities that you serve to educate first, because a lot, while they may be getting the service, are afraid to really ask the right questions. So I think we have to help them understand and educate them so that they can help be good providers and carers of the healthcare system. So education to me is critical, even in the schools, starting with your health programs and your school systems. So even on the home health care, I know with my father who had a leg infection, he had the home health care. But again, you have to sometimes educate so that they can know, and it's not repetitive, that you have those problems with the staph infections and those other things. It's a process of helping them to understand also how they should be partners with you to ensure that they receive the right care.
For our community, it's limited English and refugee and immigrant. Even if you educated us, unless you use a layman's term, we cannot understand. Even the American, native born cannot understand medical terminology. So you never heard of it, and it's first time I heard it. I don't know. They just are blank. And then when they take care of their patient, the family and the relatives are in shock stage. They are all, cannot hear and cannot see. So, like I said before, be patient and be direct and use a layman's terminology to, even if it's limited English, so we can understand.
I would like to piggyback off of with Helen. I think you have to meet people where they are, as she's saying, the schools, PTA meetings, your churches, grocery stores. I mean, maybe just have some posters. A lot of people, as my primary care physician said, a lot of people don't even know what a staph infection looks like. And they advised me that now is a higher incidence in the neighborhoods, in the communities. It's left the hospitals and now it's infiltrating the communities. And I would say, have bilingual. We see so many things in Spanish, and my heart goes out to you because you don't see a lot of translations in Chinese or Japanese or Arabic, and we have a lot of, it's a melting pot here. I'm from Evanston, Illinois, but I speak English, so I was able to acclimate when I came here. But someone that's coming from another country, if you don't speak Spanish now, most of the time you're really left out of the communication pool. So I would say have some bilingual flyers, information, pictures. Pictures speak volumes. You hand a person something with words on it, they're not going to read it. Maybe big picture, little conversation.
That's right. We had a question over here. Yes, sir.
Hello, my name is Manuel Eskildsen. I'm a geriatrician at Emory, and my question has a lot to do with what you were all just discussing, and this is mainly for Dr. Berwick and also the patient advocates. We've heard a lot today about empowering patients and how important that is, and I'm looking at it from the perspective of care transitions, and as I'm hearing all this, I'm thinking about our safety net health system here in Atlanta, the Grady Health System, and our very underserved population of people being discharged from hospitals with lots of medical problems, lots of medications, lots of complexity, and they may not have the health literacy to be able to empower themselves, to be able to use a patient-centered record. And so these patients may fall through the cracks. And this could be a double whammy in terms of the Affordable Care Act, in the sense that if we are grading hospitals and health systems based on their readmissions, and we have all these health systems for underserved populations, are these patients going to lose out because their health systems are going to be lose money because of penalties because of the populations that they serve? Thank you.
Sure. Well, Ms. Chancellor, in her very first remarks, talked about transparency. She said, I want to know. I just want to know what's going on. I think that's crucial. I think if we can get a firm commitment to making knowledge about how we're doing available to all of us, those of us that want to improve, those of us that give care, those of us that get care. It will only make things better. Yes, we're not all the same. A small rural hospital has different challenges from a major academic medical center, but Mrs. Chancellor is smart enough to understand that. And if we move toward transparency and then try to add in the storytelling and the complexity that underlies it, maybe large academic medical centers should be compared to each other, not to a small community hospital. And we need to figure out how to do it. That's a technical problem, but it begins with a commitment that the patient, the family, the community, they belong in the driver's seat. And they need knowledge, they need choices, and they need involvement of the kind that we're talking about here. I'm so excited about what I'm seeing in the room because you want to be involved, and that's the right step. And yes, I think we can figure out how to deal with some of the complexities that concern you and me about making sure that we know apples from oranges. We can tell when things, are different for other reasons. But I think it does begin with this commitment to involvement, and that begins with knowledge.
And Dr. Berwick, I know you have to go, so we'll let you run, but please do join me. We'll continue our discussion, but please do join me in thanking Dr. Berwick for his time. Thank you. Scoot down one.
Thank you very much.
Okay, so we had a couple questions, I think over here that I was missing. Why don't we get who's got a question, just so we get a sort of sense? Okay, well, let's go here then next.
Hi, Tim Sweeney with the Georgia Budget and Policy Institute. This has been really interesting, and it's primarily a provider-patient conversation. And one big picture question is how, in this campaign and in these activities, how the insurers fit in, and if that's a potential spot, for lack of a better term, if they can help manage the care and the coordination among outpatient providers. Or, I mean, it seems like in theory, there's an opportunity there where the insurer helps facilitate the conversation among the providers so that the patient knows it's happening, and so it doesn't have to just be always the responsibility on just these two parties. And so I guess just sort of how that's involved in these efforts, or if it really this is just a patient-provider thing.
So today's conversation is largely patient, provider, community leader, like you all, and including state agencies and local agencies as well. Other panelists may have some other views, but I would say that off the top of my head, there are a lot of different stakeholders who have a role in this conversation and in this change, and certainly insurers, including the Medicare program, have a big one. And I can think of a couple. One is being able to start actually paying for care coordination, right? So when we've talked to patients and we say, I understand that you want your doctors to talk to each other, but we pay on volume, on fee-for-service, on office visits and flu shots, on things. They immediately, patients intuitively say, well, they should get paid to call my specialist and coordinate. That makes sense to me. So finding payment strategies that actually reward clinicians for doing the kind of care coordination and safe transitions that we're all talking about today. Giving clinicians information on how they're doing. We were just talking about transparency in healthcare. Health insurers have a lot of information about the quality of care and the cost of that care that is delivered in this country. And so, and many of them are leading the way in publishing some of that information so that we can begin to use consumer reports not just for, restaurants and cars and toasters, but for healthcare providers, for hospitals, for nursing homes. The federal government has played an enormous leadership role through websites like Hospital Compare and Nursing Home Compare, where you can look up and see quality information today, and the science behind that is evolving. And then finally, getting information into the hands of patients, I would say, is a huge role that insurers and others can play because they can easily automatically populate. You heard Nancy earlier talking about a personal health record. We could pre-populate that with claims information so that I don't, as a patient, have to go in and manually enter that I had a flu shot last year. You have a bill for it. I had it, and you know who gave it to me, and the date. Put it in my record, right? And then I should be able to not only look in and manage my own health information, but open it up and share that with my doctor. Or better yet, coming soon, and actually CMS and the VA are already doing this, their beneficiaries and veterans can log into their personal health record, and they have a blue download button, and that button just says click here to download, and I can download my health record electronically, and then I can share it with my healthcare providers if I choose to. So I think those are some roles that I could think of. Yes, Ted?
My mother was having a surgical procedure, and she got a lot of documents to fill out. I went out to the West Coast to be with her for that procedure, and integrating all that information was something that she was not capable of doing. I did it for her. I did it on a Google Health record and printed out the 10 pages and then brought it into her pre-surgical clearance area where they said they couldn't use it and I needed to fill out their form. So we're not quite there yet in terms of making sure that what you put in you can get out and take as a usable form. Carolyn Clevenger and others at the School of Nursing are doing some great work with nursing students going to low-income, high-rise senior housing where they're actually using students to extract the data and then put it in a written health record in a meaningful way. We've talked about people with low literacy, low income, low English speaking ability. They need someone to literally translate that into a usable form that then they can take to their provider.
So I have a question here and then a question in the back. So if my roving microphones can get near the folks with questions so that I don't lose track of where they are, that'd be great. So this first table here is our first question, and then the table in the back. Thank you. Raise your hand. Thank you.
Hi, I'm Helen Haskell from Mothers Against Medical Error and the Empowered Patient Coalition. So I have a sort of more comments than question, two parts. One is when you're talking about the electronic health record, one of the critical things is that patients be able to put information in, be able to not only comment but amend to say this is not correct, because I think that's the critical lapse, that you get wrong information and it persists and persists and persists. And then the other thing that I would like to say is that I think patient information is really critical, that we need to demystify the healthcare system, maybe in a way that we don't demystify anything else. One of the things that we do is produce educational materials and have patient training, and there are other people doing the same thing, but people need to know who's who in the hospital, how to get help, what needs to happen, so that they can see when it's not happening and how it should happen. And I think those things need to be taken into the community, in courses. I mean, we've done some of our work through AARP and Consumers Union, but PTAs, churches, those are places that senior citizen centers, those are, and the schools, it really should be. And we have some patient advocacy groups that are working with middle school students. And it just needs to be something that people know from early on, that it's just common knowledge, the way that, first aid used to be common knowledge.
Right.
Anyway, so that's my comment.
Thank you, Helen. Question in the back.
Monica Parker from Wesley Woods, and Dr. Johnson is the head of our division, and we're working really, really hard to do better by our patients. I recently was in Washington lobbying for the Alzheimer's Association, trying to help with care coordination, diagnosis, and management for patients with dementing disorders. The problem is, as somebody pointed out, payment for care coordination, and then the expectation that your doctor is this omnipotent person who's going to remarkably come up with all the resources and be able to connect all the dots. So while we're talking about getting hospitals ready, I appreciate the students being here, but it has to be an ongoing way of informing and equipping doctors to better equip and help manage their patients' problems and concerns. Yeah, payment for care coordination is important, but also understanding what agencies are available to help serve us. I mean, I'm at Wesley Woods, and outside of the patients that are hospitalized, everything is referred to a social worker. How many doctors in private practice have a social worker to help coordinate care? I used to work in Social Circle, Georgia, in private practice. I didn't have that capability. So while we're talking about managing, increasing payment for care coordination, you have to give the doctors the equipment, whether it's an electronic medical record, whether it's funding to help establish or purchase the hours to get a care coordinator to help them. But doctors need help getting this done. We're not omnipotent people.
You know, and one idea that I think is interesting that comes to me as I'm listening to you is we do have a number of local and state leaders here today, and I think one of the things that clinicians, whether they're doctors, nurses, PAs, case managers, you know, as the case may be, one of the things I think we struggle with is knowing what community resources there are, so that if I have a patient who does have limited English proficiency or has transportation issues and challenges or housing issues, right, we need to look at patients as whole people, and we need to look at them in the context of their life circumstances, not the institution in which they're treating them. So I think you make an incredibly important point, which is how do we know which community resources to bring into play? So I would say to the state and local leaders, one idea might be to begin to catalog at the local level what are the key resources that healthcare providers can draw on to deliver more patient-centered and whole person care, and begin to engage and coordinate not just with other clinicians, but with other resources in the community as well that the patient may need support from. I think that's a terrific point.
Could I make a comment there?
Yes, please, Nancy.
One of the great things that has happened nationally is the major emphasis from CMS and the Administration on Aging to bring those two organizations together and to say to hospitals, you need to step outside and meet your area agency on aging and your aging services provider. At the same time, the Administration on Aging is saying to the aging providers, you need to go knock on your hospital's doors. Fortunately, in Atlanta, we've been doing that for many years anyway, so the basis is there for it. But nationally, this is a tremendous boon to being able to link ourselves in the healthcare arena with aging resources. So we've got a natural fit. We just need to make sure everyone knows how to use it. And I know our area agency on aging director is in the room.
Kathy Berger.
Kathy Berger. I don't know whether you wanted to mention something about that.
Sure. We get a microphone for Kathy, please.
But it's an underutilized resource for us in healthcare, and I think it's just sort of starting to be recognized.
Thank you. And if I could add that as the Atlanta Area Agency on Aging, we do have an information line. It's called AgeWise Connection. There's a little card out the back there, how to navigate the healthcare system. And we have 12 counselors on the phone every day. We have a resource database, a statewide resource database, 24,000 listings, and they're up to date. And just to let you know that we welcome calls, and we really do take every call from beginning to end. And just listened this morning how staff explained to us how they answer those calls and help people to connect to the right resources. So if you don't have our number, grab that card or see me. We would love to be of assistance to any of the patients we're talking about today.
Thank you so much, Kathy. And there are actually a number of pieces of information on that back table from a variety of community organizations here today. So do take a moment and take a look at that. Do we have other questions or comments? Yes, ma'am.
Hello, my name is Vicki Carnes. I'm a diabetes educator and health advocate with the Georgia Free Clinic Network. And John Riley here is here with the Georgia Diabetes Coalition. There's over 1 million people in Georgia that have diabetes, and for every 2, there's 1 walking around that doesn't know it. So I've encountered, let's say, a 55-year-old African-American male who's hospitalized with a stroke, didn't know he had diabetes. So let's just imagine, I'm trying to help me understand, care coordination. Let's just say he's significantly disabled, he qualifies for Medicaid. So he's discharged with home health, and he has no diabetes, he knows nothing about diabetes. Medicaid doesn't cover diabetes education. That's his primary #1 chronic illness. I'm lost for what resources are available in that case as far as home health, providing diabetes education. Care coordination, he may be back in 30 days.
Right, and I think that, and our panelists may want to comment, but I think that makes the point for us, that at the local level, we need to not develop systems so that only certain social services agencies have access to a set of community resources. I mean, Kathy just talked about the great resource set that the area agencies on aging have. How do we begin to share that information, particularly, I would add, in a digital age, with each other, so that different social services agencies, community organizations, and healthcare providers can all connect and use the same information? I know we had a question over here. We had two questions.
Hi, couple of comments and a question. My name is Jan Wilkerson. I work for the Georgia Association for Primary Health Care, and we have a lot of partners in the room, including Dr. Mims and the Georgia Medical Care Foundation, as well as Kathy Berger and her association. For those of you who do not know us, we represent the more than 130 federally qualified community health centers in Georgia. And that means that regardless of their ability to pay, patients are able to walk into one of our clinics, see a physician. There's nurse practitioners as well, but to see a physician, get the care that they need based on their ability to pay. The one thing that they have to do is to prove their income, and then we research it. But most of these clinics also provide a medication pharmacy type thing for, again, folks who cannot afford their care. And to make sure, because it's not enough to say you have hypertension. If you can't get the drugs, then you're going to have hypertension and stroke and so on. For the discussion about the diabetes care, all of the clinics within Georgia do provide diabetes care and diabetes education. Some of that is with CDEs and some of it is not. But the comment or the thing that I wanted to make earlier on, there was a discussion about engaging the patients in this care. One of the things about each community health center is they are community owned and community operated. 51% of their community board is users of the health center. So whenever there is a feedback or a discussion about the care provided in the healthcare system in that community, it goes back to the board and they make those decisions. There is a lot going on with community health centers as part of the safety net providers and things. But from the hospital viewpoint, I guess what I would like to say, or the comment I would like to make, is we do recognize a lot of resources within those communities. There are significant opportunities for us to partner. And a lot of times, my background is in RN and quality. So a lot of times, if we can't get to the front door of the hospital, we go to the quality department and talk about continuity of care and how all of that feeds together. But there is an opportunity. We are getting flooded every day with calls from people who have lost their job, have no health insurance, and they need the care that is given. But also talking about health disparities. Our patients that we serve have not one, but probably 3 to 4 average chronic diseases. And so diabetes and dialysis are just a way of life for them. Mom had it, grandma had it, I'm going to get it. And there's not a lot. So Care Transitions has been awesome because I got to sit on part of that to make that. But what I would suggest or a question that I'd like to discuss is there is significant opportunity to partner with the hospitals, with the community organizations, better care. And I'm going to talk to you about that. But how can we relate and how can we help support you all in this room to get that done and to take care of those patients? That's what I want to know.
That's fabulous. That's exactly why we're here today. And there are actually a number of staff in there. What we'd like you to do, and I'm going to actually turn it over in a moment to Holly to talk about some next steps. But one of the things we want you to do is to keep talking to each other. We have this fabulous mix in the room of consumer advocates and some of the most progressive healthcare providers in the country who are willing to partner and engage. So we need to talk to each other. Certainly, I think our consumer advocate speakers can help connect you with local patients and families and advocates who might be willing to engage and create those opportunities for partnership. So I think that's terrific. Okay, last question or comment, because I think we're going to wrap up.
Comment. I think I call it the paradigm ripple of change. it need to be telemed kiosks in various communities, especially when you have people living under viaducts. The health advocate in that community basically is alerted once a certain amount of information is gathered in that kiosk. That kiosk goes back to a what you call the data bank or data warehouse that's at whatever local medical center or hospital. They will alert a doctor that's on call for that particular specialty or that particular problem. That health advocate goes back into that community and goes directly to that particular location where that kiosk is. And then we would find that individual person who have, I would say, accessed that particular kiosk for whatever symptoms they may have. The literacy level can be done automatically through the data bank. Basically, through the basic questions that they would be asked at the beginning, that would tell us what literacy level that they're on in terms of helping them to understand what information they need to get or be educated. If they speak Mandarin Chinese, then it would automatically shift over to Mandarin. If they speak the same kiosk, if they speak Puerto Rican language in Spanish, which has slight slang than regular Spanish, it would flip directly over to that particular language in terms of explanation. These particular data software is available to everyone right now that could be utilized. And this is one of the projects that we're working on right now, is to prepare for these kiosks in these various communities that would be embedded in the walls, that no one can take them out, vandalize them, and that whole thing also.
Yeah.
So then we use Skype to get the patient to talk directly with that physician and that healthcare provider, or with that particular health advocate, so we can have a follow-up.
And I think that's terrific. And I would say that Chicago, I know, is looking at doing some really extraordinary things as well with technology for patients. But my cautionary tale when it comes to healthcare and technology is you can't, if we've spent a lot of time talking today about how our current problems are a function of the system of care, you heard Dr. Berwick talk about that. So if we automate the current system of care, we'll just be able to do the wrong thing faster. Yes. So we just have to figure out, right, how do we get patients at the table to talk to the healthcare system about truly redesigning it. So any last minute comments from the panel before I turn it over to Holly? Oh, I'm sorry, go, sure. It's hard, our microphones need to be like next to you guys because I can't see too well with the lights.
Hello, my name is Stacy Lang, and I'm here as an individual who's, like many people here, been affected by the healthcare system. But one of the concerns that I just wanted to bring up before we part is about the importance of patient-centered training in terms of continuing education and credits to keep your license, as well as coming up through the nurses and doctors training originally. I don't think I've really heard a whole lot about that, and I think it's really critical.
I couldn't agree more. I couldn't agree more. And I actually think, I know we have some medical student groups in the room today as well, that the geriatricians, Ted, you guys offer a really unique perspective about what wellness means and what getting better means for older people that I wish we could translate to the rest of the specialties. Yeah. Okay, so let me go ahead and turn it over to Holly, who's going to talk about some next steps.
Yes, well, first off, thanks everyone for coming out. I think this has been great. The conversation isn't coming across as just a token one, but one of genuine interest by everyone to collectively work on this issue. And, I appreciate the panelists being here, and Dr. Berwick, is amazing, and his leadership and kind of bringing this to the people. So we really appreciate that. Just some concrete next steps with the Campaign for Better Care. To start, if you didn't do so whenever you registered for this event, go to www.campaignforbettercare.org and sign up for email alerts. And then that way you guys can stay up to the know on things that are going on both on a national level, but also a local level, because we do have some very Georgia and Atlantic specific information that's happening, and we'd like for you guys to be involved. We have a camera that's been recording this, so if you have any colleagues or friends that were unable to make it, please forward it to them. We'll alert you guys via email, when that is available online, and we definitely encourage you to share it, pass it on, use it as a starting point for conversations within your own organization or your own coalitions, so that we're able to better address these conversations. We also have an evaluation form in your packet. If you could please fill that out. helps us establish better programs and make sure that what we're providing to you guys is what you need and relevant and whatnot. So just takes a couple of minutes, and we really would appreciate you filling it out. The thing we're most excited about, almost to some degree, is a community event on June 28th here in Atlanta. And it's going to be held at the Atlanta Community Food Bank. It's from 6 to 8. It's a Tuesday night, and it's meant for the community. So we're expecting about 200 different consumers in the room. We're working in partnership with some of the panelists here, the Coalition, the People's Agenda, Urban League of Georgia, Center for Pan-Asian Community Services, Campaign for Better Care, Georgians for a Healthy Future, and us, Georgia Watch, and Piedmont Healthcare. So if this is something that you guys would want to be a part of, you can have a table at the event. Please send representatives if this is something that you would want to pass along to your constituents, your members, or the folks that you work with. Get in touch with me. My card is on the back table, but my email address is hlang@georgiawatch.org. And we strongly encourage everyone to participate in this event. And on that note, we have had a lot of very strong conversation here, and we do see this as just the beginning. So we're going to establish a Campaign for Better Care Atlanta-based leadership team to collectively address these issues on an ongoing basis. So if you have any interest in being a part of this, which will help empower consumers in shaping innovative programs within the community, as well as some of the issues and concerns that you've brought as providers who are working in this, or in your experience in home-based care and in diabetes and whatnot, we need you to be a part of this because we can't do it alone. And while we can think about some of the issues that may be there, without your voice as part of this conversation, we won't be able to accomplish it. So there's a sign-up sheet on the back table. Please sign up. We would love to have you as part of it, and everyone that does sign up will soon receive kind of instructions and directives as towards our next step. So again, thank you so much for coming out today, and we look forward to talking with y'all again soon.
Thanks, everybody. It was a terrific day.